Oppenheim says they have decreased the open heart surgery percentages from 40% to 5% in the patients. So that means 95% of the patients going into those patients do not require, they require ophthalmology. Sometimes a little bit aggressive ophthalmology, but they can avoid the last bit of that very, because children have already undergone 7 to 8 surgeries, then they are going to do any ophthalmic surgery. So that's very, very important that we try to reduce the number of surgeries that patients are undergoing. So that's the last one. And ophthalmic surgery has other problems, like sometimes the patient speech worsens and all those issues. So if you can avoid the last surgery, it's good. This his 25-30-year-old career reduced the number. But in our center, what we see is 60% of the patients would probably require ophthalmic surgery if you really leave it like that. So we're trying to reduce that amount, and hopefully we can. We know only by maybe in another 4 or 5 years we will. So this is the technique. This is a wide cleft. Probably it's not possible to repair with other technique. It's almost there is no lateral shells, and we use the buccal flap. That's the flap. It's a buccal myomycosis flap. So it's got the buccinator and the mucosa. It has a blood supply, but it is not really recorded. That it has a dedicated vessel is not always observable. So you can call it random pattern, not an ideal axial pattern flap. And so, yeah, there is the closure. You see the buccal flap has closed the entire cleft, and that's when we divided the buccal flap. So buccal flap, the only disadvantage is you have to divide the buccal flap. So this is the article. Robert Mann's article in 2000.